professor of psychiatry in the Department of Psychiatry and a clinician scientist here at CAMH, and I would like to welcome my colleague and friend, Dr. Michele Fornaro. He is an assistant professor in the University of Frederico in Naples, and he did his MD in the University of Genoa and his PhD and medical residency in the University of Pisa, and he spent almost 4 years and a half, right, in the United States, doing postdoctoral work in many top-ranked institutes there. And so it's our pleasure to receive you and to learn from you on such an exciting topic. Thank you.
So actually, I'm the one that says thank you to you for being here now, and the special thanks goes to my valued friend and colleague, Andrea Fer Carvalho, for being here today with you. Treatment-resistant bipolar disorders. I must admit that it may sound a bit odd or even bizarre to many of us to talk about treatment resistance in psychiatry in the year 2019, namely in bipolar disorders in this context. And the reason why is there is such a burgeoning and a huge number of different pharmacological and non-pharmacological interventions that are being made available within the past decades. So this is just a sneak peek about the United States Food and Drug Administration drugs that have been recently approved over the years, actually, in the treatment of different phases of different types of bipolar disorders. And cariprazine was just recently granted extended approval even in the treatment of the acute depression associated to bipolar disorder type 1 BD. So no matter what, we are still dealing with a considerable number of cases that fail to respond in an adequate or appropriate way, and we will go back together later about what adequate is. They still do not respond as they should, or we should expect to our approved medication, even for non-treatment resistant bipolar disorder patients. So one of the basic explanations for this is that we know little about the neurobiology underpinning bipolar disorder. Obviously, which is a quite intuitive explanation. There are other potential explanations that we don't usually take into account every day. One of these is the nosology shortcomings and the pitfalls associated with the definitions of bipolar disorders, including treatment-resistant bipolar disorder patients. Here, you can see there are multiple concepts. I'm not going to fuss or delve in details right now, but still, as a clinician, you are also a clinician, you know. You may already know what predominant polarity is. You may already know what else. What these concepts are. So predominant polarity means that a given drug, say a given intervention, is either more effective in the prevention of mania or in the prevention or the recurrence of depression in bipolar disorder. Say, for example, lithium is approved in the treatment and the prevention of manic recurrence. So the predominant polarity is the ratio between the number of patients you need to treat in order to get a prevention of depression, and the denominator is the prevention of mania. So 1.39, which is the usual reference for lithium, means that it's more effective in the prevention of mania. Predominant polarity is a concept that applies to almost 40% of the patients we see in everyday clinical practice in the outpatient setting, but still this is not the real focus of our presentation. I just want to recall this concept, and you may want to recall this as well in the question time, I hope so. So this is also a sneak peek about the definitions and the outcomes you usually look at in the treatment of bipolar disorders, no matter if they are treatment-resistant cases or not. So as you can see, here we have depression, and here is mania. It usually is 8 weeks, it may be even 12 weeks, depending on the clinical trials, different source of evidence. And 4 weeks or even 3 weeks is the usual time frame people do consider in the treatment. It is RCT, so randomized clinical trial. Again, this is evidence-based world, not necessarily real-world clinical practice, but still, this is the time frame we usually look at. And as you can see, we have different concepts here. One is response, which is a quite intuitive one. one other is remission. So it depends on what we are talking about. It must be very clear what is that, what is not. So response means that is a symptomatic based definition. So we are going to achieve response, yes or no, is a dichotomous outcome, like alive, dead, or pregnant, not pregnant, whatever. So it's a black and white. Black and white doesn't work for real things. Black and white is possibly an ideal outcome. This is not real life. So again, we need this as a surrogate endpoint in order to be practical when we plan, we design, we interpret the result of a clinical trial. But this is something that we take with much caution. So it's a total score. So say for example that an acute treatment for acute mania, we score the baseline with the Montgomery-Åsberg, the MADRS rating scale, and then we look at the score after, say for example, we said 8 weeks an example in this case, and then we say this treatment was able to was associated with response. No, this is not necessarily the true word. This treatment was efficacious, maybe effective, this is a different concept here, in reducing the total score of a scale after 8 weeks. We are not rating scales, our patients are alive people. So we may still use surrogate, but this is not what real world is. So again, we may look at the symptom-based rating, but unfortunately psychiatry is a field where we still not treat disease, we treat disorders. This is in sharp contrast with other medical fields. And most of our interventions, regardless pharmacology, neuromodulatory or psychotherapy or complex treatments, are symptom-based, simple targeting treatments. And this is also misleading because symptoms means that we do scotomize. We look at a specific mole rather than the whole picture. So again, remission. What remission is? Remission is usually referred to as a threshold, say for example 6 or 7, total score at the Hamilton, Tenet, Madras, and point. Recurrence means prevention of a new episode of the same polarity of the index episode, and then its maintenance, which should be the real, ideally, it should be the ideal outcome, because when treating patients, psychiatric patient, bipolar patient, whatever we are going to treat, the real endpoint is lifetime. This is a disease, a condition, bipolar disorder, we cannot recover. There's no way to heal the patients. In the ideal world, we can just manage and handle the acute, the problem associated with that. So what treatment resistant is? We are now looking at treatment resistant bipolar disorder, and then the E stands for depression. Well, we said that there's no consensus about the definition. So still people strive at providing definition. With problems is not no, but we know exactly it is very prevalent. So almost half of the patients, not that high, but almost half of the patients we see in clinical practice, regardless they are out or inpatient, they do fail to achieve response, a clinically meaningful response after a few weeks. So even if we are looking at the non-symptom-based outcomes, say for example the clinical global impression scales or the improvement model, the CGI-S, we see that many patients fail to achieve a meaningful response. Even in this case, one should wonder, what is clinically meaningful? Clinically meaningful is something that takes into account the social functioning, and so it's a more complex outcome. Still, almost of the patients do not respond, even in the systematic treatment intervention, the CFBD program. People from Barcelona, we are in touch with these colleagues too, our friends, led by Dr. Vieta, are especially Hidalgo, Mazzei in the year 2019, they provided a definition for multiple treatment response failure. So multiple does not just mean 2 or more. Multiple means a sequenced algorithm or different approach, and this is something that is not usually acknowledged by the standard definitions. What is what are the issues associated with treatment resistance in bipolar disorder? Obviously, people who are treatment resistant, they do not usually seek for another medical consultation. Even when we provide or we offer them the opportunity for more effective intervention, like the ECT, the electroconvulsive treatment therapy, they usually say, okay, why should I go a new trial, especially a last resort one? Also, these people is more, vulnerable to suicidal behaviors. They are very, at higher risk for suicidal misconduct and behaviors. And there are also higher rates of polypharmacy. Polypharmacy is not necessarily a bad thing per se, but it can be, as far as people have higher rates of side effects, lower adherence to medication, lower compliance. So there are and the higher rates of dropout even in the clinical practice in our office. So there are also higher rates of service utilization and other things we don't really like to see, but still we see very frequently. So what treatment-resistant bipolar depression is, there are different proposals, and which is in contrast with treatment-resistant mania. One of the possible explanations for this is that treatment-resistant mania, especially euthymic mania, is not that frequent as a phenotype. There are some patients that fail to respond to either lithium or complex multiple treatments, including antipsychotics, even ECT, but they are not that frequent as people that are failing to achieve a sustained response if you treat a baseline and index episode of depression. One of the reasons for this is that as biological different profile for this kind of patients, because mania is usually time-limited phenomenon, so it takes a lot of catecholamines and probably other, it's a storm that you cannot sustain for a long time. This is the natural course of the disease. But what happens if the natural course is not natural anymore? So they may be still treatment-resistant many patients, especially if they are addicted to stimulants, they are drug addicted. And this is something that occurs very frequently as well. So most of the guidelines, unfortunately, do not really pay attention to this kind of patients that are still frequent, relatively frequent in the clinical practice, and are the ones that are most burdensome for many, considering many different issues. So the treatment guidelines are guidelines because they should guide us. But this is not the Torah, the Bible, the Quran, and you can continue, obviously, how long you want. But you can refer to this, you must refer to this, because that's an ideal word. The patients you see in the literature are the ideal patients. The ideal patient is not necessarily the real patient. Actually, the ideal patient is one of the few patients in a vast majority of patients that are complex comorbidity patients. So even if you look at guidelines, you want to ask something right now? Oh no, so you're analyzing.
When you're done your thoughts,
No,
sorry.
absolutely, no worry, you can if you want.
I was just wondering for the studies on treatment-resistant mania, are those done on inpatients or outpatient population? I'm just thinking about controlling for things like substance use and.
Well, yeah, ideally we should control. This is one of the issues we will talk later in few slides. But unfortunately, we cannot control for this because this kind of population are usually the ones that is missed out. Most of the randomized clinical trials we see in the literature do exclude these patients. So special population, highly suicidal patients, pregnant patients, obviously treatment-resistant cases are the ones that the sponsor, which is often a brand, a pharmaceutical brand, does not want you to cover because they are less likely to respond. Well, this is another history. I don't know how much time I have here, but still you consider this. That in most of the cases, this is a debated issue, by the way, very debated, highly debated issue. Some people say you should just skip those people who are more severe cases when you enroll for a study in the baseline. And the reason why is that if you are very severe, you are less likely to get the benefit. Well, things are more complicated because, as I said before, the surrogate outcome of response bases on the total score of rating scale. So if I'm very severe, say for example the range for the MA2 depression rating scale, as far as I remember, I may be wrong, is 0 to 54, right? So this is what should be. So say for example that I'm a moderate, quite severe depressed patient. I'm talking about current major depressive episode. So I score, for example, like say 28 or even higher at the entrance of the study. I'm depressed, no doubt, because some trials do just require you to be 14, 16, 18, or something like that, depending on the source. I'm depressed. Then, say for example, I enter the trial by a score of 40. This is easier. And then I do follow the trial, and I do receive the medication for 8 weeks for the time of the trial, say that I'm at the end point of the trial. Now my Hamilton depression total score is 14. No, sorry, 22. Wait a second. 18. So 18. I entered as 40, right? So I had a response because my total score is 50% lower in the total number. I compared to the one I had when I was enrolled, but still I'm depressed. So I know that there's a lot of debate about this because this kind of threshold effect has been faced. So people is not, on the same, perspective. So there's people that say this is an issue, this is not. So literature is not, unequivocal about this kind of issues. But still, this is one of the main paradoxes we see when we attempt to translate the real world, actually, the evidence-based medicine to the real world clinical practice. So it is an ideal outcome, it is an ideal surrogate. So again, most of the guidelines do based on randomized clinical trials, which is the best ranked evidence for primary research. But still, you can do better. Even trials that have low power, as a standing alone trial can be pooled in a meta-analysis, which should be seen as the best evidence. Absolutely, a well-conducted meta-analysis is nowadays the best kind of evidence we can count on, but it must be a well-conducted one. It must be a clinician thinking meta-analysis. Otherwise, it's just I respect obviously people I work to. We need to. It's a statistician job, which is another story. We respect, but this is not what the patient benefits from. So again, treatment-resistant depression and multitherapy, we're not going to, to look to all the details here, but as I mentioned before, most of the definitions rely on a symptom-based definition paradigm. We can look at the syndromal definition, the clinical global impression I mentioned before, or ideally to the functional outcomes, so the FAST and other kind of ratings like that. So ECT is included in the multitherapy paradigm. And still, we don't have such a rigorous approach for mania, treatment-resistant mania. André, who is here, was one of the first, possibly the first, that in his nice book, the green one by Oxford Press, I'm going to, to sell your book now. So we have a lot of fellows that will buy. So I'm joking, sorry. So basically, is now considering multiple steps of failure. So again, we are going beyond the paradigm, the pitfalls of the dichotomous outcome, and we are also trying to do what other people already do. Fekadu and other colleagues in the UK already did with unipolar treatment-resistant depression. So we have a metric outcome. We do a linear regression analysis to predict the amount of variance we are able to, to change. So variance is a statistical concept. Say in plain English is something that you will take into account and understand how much of the different outcome will change depending on what you predict. So we can go we can go forward from this. So is there any treatment-resistant bipolar disorder in the long run? Well, it may look like a paradox here, because if somebody achieved the recovery response in the acute phase, what kind of treatment resistance are we talking about? Obviously, this is a paradox. But still, the ultimate outcome we should look at is the long-term prophylaxis of recurrence. Usually we look at the same polarity, the prevention of recurrence of the same mood episode polarity. But still again, in the ideal world, we should pave the ground to prevent recurrence. So the higher the amount of time the patient spends free from an acute phase, the better our outcome. And still again, if we look at euthymia, we usually talk about euthymia. Euthymia doesn't exist. We usually don't think about this, but from a psychopathological and clinical standpoint, there's no euthymia for patients, not even for average human beings, not necessarily bipolar. Because euthymia means that you are not going to reach the threshold set for the episode, say it a mania or depression, but this is an ideal concept once again. So every time, and also consider this, that most of the patients who are diagnosed with bipolar disorders have what we call a trait, a stable trait. So a stable trait is a putative endophenotype. We will find the patients, and even in the first degree relatives, even if they have no diagnosis for the same condition, this kind of trait will be stable regardless of the acute overimposed mood episode or the treatment they are going to receive, so the mood phase. There's also the scale concept. The scale is what you get when you are acutely ill, and then you get a new, cognitive impairment or other kind of sequelae consequence after the acute phase of the mood disorders. So, trait, scare are two different concepts that go beyond the acute phase. So, euthymia among people who are, for example, highly impulsive or do have cognitive or soft neurological signs, things, or like or other kind of cognitive shortcomings and issues, is no euthymia for them. You may just talk of threshold even here. So let's look at quickly look at our systematic review and meta-analysis that I did with my valued friend here, and is the one that oversaw everything. So is the one that put the most innovative and critical thinking. We will work entirely together for this. So I'm not going to delve in details about the statistics behind this, but as far as you may be concerned about, we were able to review the literature for different intervention, even pharmacological and non-pharmacological intervention, or RCT studies involving patients whose baseline samples included at least 75% of bipolar cases. And the reason why is that we were looking to something that was powered enough for this kind of patients. So if I'm going to enroll patients that are not the primary focus of the study, maybe the outcomes, the metrics, the measurement bias, and other kind of bias may affect the validity, not just the reliability, but also the validity of what you are going to collect. So reliability means that I'm, if I go to, if I'm going to measure my weight every day, assuming that I'm not going to change every day, obviously, and I'm assuming that I'm at the same level of disease, say for example, assuming that everything else is all the same, every time I get the same result, this is reliability. Every time, the measure is reliable. But if the measure says that I'm 125 kilograms, it is reliable, definitely it is, but unfortunately for me, I'm not that heavy. So validity is the other concept. That means that every time I make a measurement, it is going very close to the real value. So ideally, the rating we are doing, it is set for balancing reliability and validity. So how many trials and definitions we were able to detect in the literature? Unfortunately, most of the studies set the usual operational definition for treatment-resistant bipolar depression as the failure to achieve response after 2 or more trials with antidepressant. Why I say unfortunately? Because even monotherapy can be an adequate trial. But as a clinician, we know that antidepressant monotherapy is not adequate at all for people who have a diagnosis of bipolar disorder, especially if they already have an established diagnosis of bipolar disorder. So monotherapy with antidepressant, even in the acute phase of bipolar disorder means higher rate of treatment-emergent mania, of long-term rapid cyclicity, of mood cycling, and higher rates of suicide and mixed features. Mixed features is one of the worst things that we should look at, even if we usually don't, because this is one of the unmet needs of current guidelines, but still it is one of the most frequent scenarios in the clinical practice. And I really hope you will ask me again about this in the question time. Please do. Absolutely, please do, about the mixed features, absolutely. It is very important for any clinician. So again, 2 or more treatment failures to antidepressant, even monotherapy. Why? Because most of the trials were sponsored by the brands. So as a pharmaceutical brand, I'm going not to fuss about psychotherapy. That's also a red flag, because psychotherapy should not consider as an option. Psychotherapy should be considered as part of any kind of treatment, especially when dealing with very complex and complicated patients, like treatment-resistant patients. Unless you do good psychotherapy, any kind of approach is a waste of time, especially for people who are already, skeptical, and they must be against, the drugs and other kind of treatments, even about neuromodulatory intervention. So please do not consider this as an entire one. The fact that it's not part of the reviewed literature here, it is a publication bias result. So evidence-based does not necessarily mean evidence of absence. So you may find, you may not find, but even if something is not there, there are many potential explanations for this. So what about treatment mania? So treatment mania is funny because I will look to this back in a few seconds, because treatment mania is usually seen as a failure to, I will tell you, so I don't remember where in the slide is, but anyway, treatment-resistant mania usually is defined as 0.8 millimole per liter lithium the serum level, and the failure to achieve a response to acute mania, even if you have a quite good lithium serum level, even if you use antipsychotics altogether. Well, it may occur. It is not that frequent unless you are on, say, for example, phencyclidine or other kind of offensive stuff that are quite popular, but still is a special case. So what about treatment-resistant depression? We found a quite interesting odds ratio result, which is an effect size, so I don't want to delve in statistics here, but still say this is the ratio between the people that are likely to get benefit in the among the cases and against those that are controls. But so, say it in plain English, pramipexole was a quite intriguing option. And again, we must interpret this with high caution, because in the clinical practice, we know that drugs like pramipexole, ropinirole, and drugs that act as D3 and D4 dopamine agonists are usually associated with higher rates of impulsivity, higher anxiety levels. So treatment-resistant patients are usually the ones that already have high levels of impulsivity and anxiety, including suicidal behavior. So, and also we already know that even people who are Parkinson's disease people, but not necessarily just Parkinson's disease patients, are at higher risk for pathological jealousy and gambling. So please be careful when considering this. This is just an idea. So careful, careful, and careful. Ketamine, oh, finally we see the ketamine thing, which is a very fancy and popular, option right nowadays. So ketamine was interesting. It is two trials supporting ketamine, but I want to stress this out for you. Ketamine trials were the ones carried on people who were receiving the intravenous injection of esketamine. So the FDA, the US FDA, recently granted approval for esketamine as a nasal spray, even in the treatment of treatment-resistant major depression, unipolar depression. So we must be very cautious in translating the evidence for something that was studied for something else. So even the route of administration do matter. And also we don't really know yet what the putative mechanism for ketamine is. Some people say it is an NMDA glutamate antagonist. Some people refuse. Absolutely, it is, even if it works, it is affected, are blunted, partially blunted by lamotrigine. This is a complex issue, and but if you want, we can discuss about this in the question time later. And also, we don't really know about the opioid receptor activity of ketamine. There are many putative, mechanisms involved into this. So please, just bear in mind that it's a promising avenue, but still, we don't really know what happens later. What is intriguing to me is that ketamine is a different paradigm here. It is not an 8-week thing. It is a few hours, a few days thing. And that the effect blunts away over 1 or 2 weeks, unless you repeat the injection. So, acceptability. We were not just looking at the efficacy of the treatment. We were looking also about the side effects. So, acceptability means drop out due to any reason, while tolerability is usually considered dropout due to adverse events. So we don't want to, to force in the operational definition, but still we want to look at this. Say it in plain English, the number tell you that the treatments were quite tolerated. This is the basic, the message to grasp. So let's go here, and still we are now talking about treatment-resistant bipolar depression, This was no surprise to me. ECT was a very, very effective treatment, also quite well tolerated one, but we were not able to compare treatment-resistant bipolar depression with healthy controls, obviously, because no trial should be feasible due to ethical concerns. You cannot enroll somebody who is totally healthy, supposed to be healthy, and then undergo an ECT, especially if it is a 8 or more, application, temporal application. But at the end of the day, ECT is safer than many other people usually think, even in Europe. And unfortunately, this is a very big problem in places like Italy, France, and other border countries. ECT is an outstanding treatment. Should not seen as the last resort, absolutely. We are in a pharmacocentric world. We are driven by the brands who are drug sponsors. So even the evidence comes after for something that is not drug-based. This is just a consequence of practical issues. This is not what necessarily should be. So, for example, ECT is effective even for people who are currently pregnant, because the amniotic, I don't know if this is correct in English, but amniotic fluid is a very terrible way to conduct electricity over the body. So it's safer for the newborn, not yet the newborn, but somebody who is going to be a newborn. So the fetus. So it's also effective because unless you have a deep venous thrombosis or things like that, you are getting no trouble. So even if you undergo bitemporal ACT, you may obviously have transient amnesia, but it's something that is not that bad. Especially if you compare to antipsychotics, who may, not every antipsychotic, but some of them may result in metabolic syndrome or cognitive impairment, or other treatments like lithium, which is obviously the silver bullet, the cornerstone treatment of bipolar disorder, still has a narrow therapeutic index. So again, do not consider ACT as the last resort. If you do that, obviously you are going to treat patients that were not necessarily treatment-resistant cases, but they ended as treatment-resistant because of the inability to receive adequate treatments when they were still effective. So what is good here is that the treatment was almost as effective as treatment-resistant as ECT is for unipolar treatment-resistant patients. So it is an established treatment, so this is good for us. So let's go again to treatment mania, treatment-resistant mania. Rapid application with clozapine is also an option. Honestly, this is not something that I usually do in my clinical practice, but it can be considered. We already know that clozapine is the gold standard treatment for treatment-resistant schizophrenia. Usually, we just consider that for this patient. Also, this kind of drug may be, has some concerns in terms of safety, but still is something that we can handle if we know. So clozapine is something we usually low titrate in the patients because of the alpha-1 antagonism, which means hypotension. So hypotension can also be, to some extent, viewed manic, especially mixed mania. So what else? Yeah, obviously, there are concerns about the safety associated with the white blood cells. So you may end in neutropenia, so low numbers of neutrophils, and also eosinophilia, which is high number of eosinophilic blood cells. And also, there's also a chance for lowering the threshold of seizure. So a good idea should be combining this kind of medication with benzodiazepines or standard mood stabilizers, which are also the anticonvulsant like valproate or carbamazepine. This is good for people who are manic. And what else? Yeah, acute myocarditis is a potential outcome, but it's not that frequent. In the long run, you may end in the hypertrophic myocardopathy. This is something that you already know, obviously. So again, this is an option we may want to consider. Treatment-emergent mania is something that can occur among people who are either resistant or non-resistant acute depression. So and we are almost done finally. So what is the caveat here? What is the warning signal, the warning message, the hazard here for us? Please, do not forget that the operational definition are almost missing here. So you may say, okay, nice, This was a nice study. I like it. It was a nice people. Maybe, you know, it's also a funny guy from Italy. I hope you think so. But still, what is the end message here? I know that there's no consensus about the operational definition. Who cares? Who cares? My patient don't care. I don't. Well, you should not do act like this, in my opinion, because this is even a negative or a null result, or maybe actually a non-conclusive result, is a high-yield result in some instances. Because if this is the one we need to consider when we want to move next, and moving next means that we need to collect homogeneous samples to forward to our basic science colleagues. If I'm going to collect blood for putative biomarkers for patients that you diagnose as schizophrenic and you diagnose as bipolar and I'm diagnosing as a healthy or whatever, they will not find any signal, not even with big numbers, because the sample must be heterogeneous. Remember what I said before. It cannot be, maybe it is not a valid diagnosis, but it's a reliable one. So at this time, even a reliable mistake is better than a valid apparent good result, but which is actually a mistake. So this is one of the caveats. We have no conclusive statement and definition, but still we must look at. So what about the SGA, for example? Well, unfortunately for us, we were not able to have a good number of studies to pull for this. But this is possibly due to a publication bias. So newer generation drugs or drugs that have been recently released in the market are obviously the ones that have less evidence, either in support or in discharge, because they were not available, not yet. So this not means that there's no evidence for them. This is evidence of no evidence is another thing. So especially for second generation, which are actually third generation antipsychotics. So you are here in a beautiful department which has a long history and tradition about this. And I'm obviously, you know who I'm talking about, Professor Seaman and his team. So we have a gorgeous, outstanding tradition about dopamine D2 receptor modulators. So especially third generation antipsychotics that are able to interact and have a fast time in dissociation with the postsynaptic D2 receptors should be emotion regulators. This is what the evidence may say in few years. So watchful look for this and wait for this potential outcome. So yeah, the meta-analysis was a preliminary one, inconsistent operational definition. So this is the last slide here. So you may wonder, I can read or I can tell you no matter what, but then you can follow. Obviously, by the way, all the slides are for free, or whatever. If you want, they are here for you. So feel free to take a copy if you wish. I would like so. So, it was not until a long time ago, maybe 2 decades ago, or even less than that peptic ulcer was considered a disorder treatment resistant when non-responsive to anti-acids, antibiotics. We know that they usually prescribe medication for that, but also to psychoanalysis. Because at that time, and we are not talking about 19th century, but a few decades ago, at that time, mid-80s, say, for example, that was considered a psychosomatic disorder. So, I'm not talking about psychoanalysis. I'm talking about psychoanalysis for peptic ulcer. So that was not treatment resistant, was pseudo resistance. So we must rely on clinically meaningful or neurobiologically grounded definitions. Unless we do that, we end in a very good efforts in terms of statistics, publication. I can publish whatever I want, maybe, hopefully, but still, this is not necessarily what the patient needs. So the paradigm must be a valid one. I want to stress this out for the 3rd time in a row. Valid one, not just a reliable one. So here also treatment resistant is a pharmacocentric concept. Please don't disregard psychotherapy or ACT or other interventions. And you may wonder, what about treatment, say TMS? Well, we were looking at this transcranial magnetic stimulation, but unfortunately there were few studies at this time, And the only few we found were not enrolling in a sufficient number of patients with treatment-resistant. And what we found is that possibly this is not, I'm not that confident that this is going to work. But still, we want to see more evidence and support for in this trial. So you already got the take-home message, and now you got my thank you for your attention and your time. I hope that you are going to, to get the Niagara Falls question time.
I have a question for you. How do you think the field will move forward? And what's your opinion about other measures or real-time measures of mood, like smartphones, and do you think that would be the future or not?
Oh, thank you for this question, which is a nice one, because it requires me to take different issues in consideration. So the first part of the question was, what is the future in your opinion? What is going to happen? Which is the next step in the field? Well, I'm one of the guys that is very, confident that precision medicine will shift the pendulum. And in the RDOC, the research domain criteria, age, we have great expectation about combining different information from the clinical practice. So psychopathology, applied psychopathology, we cannot regret any time, no matter what. And the proteomics, inflammatory cytokines, or neuroimaging, or genetics. There's no, in my opinion, there's no avenue we should just focus on. There are multiple avenues that are going to the same hub. And the hub is the big data, the cluster analysis, and machine learning. So again, I will stress this out one more time. It is important to collect information from different perspectives, like even social works, even psychotherapy, even psychoanalysis, even psychopharmacology. No matter what, they must merge. They will give us the clusters. So it is possibly too simple as an example, but still we are cluster analysis means that the roots of the tree are on the top. We start from the roots, and then we end, ideally, we should end in the common branch for everything. So the second part of the question, what do you think about the tools that are now available for patients, say for example, smartphone recording? Well, I know there's quite a vivid interest about this since a few years, maybe in the past 3 to 5 years, some groups are collecting information. But I'm not very an enthusiast about this for many reasons. First of all, if you have a bipolar patient and you ask him or her, please use your phone multiple times of the day, you are telling him or her, please do not sleep tonight, stay in front of an electronic device and get even worse manic. This is a joke, but maybe it's not. Second thing is that you are talking about a patient who is already very, willing to adhere to your instruction. So there's a high level of medical adherence. So treatment-resistant patients usually are not that adherent. So they may either be pseudo-resistant cases. You may think that they were taking the medication, they weren't, or maybe they can be treatment-resistant bipolar patients who are also adherent, especially if they are comorbid with OCD. But in this case, this is not necessarily a good thing, because the propensity of response and long-term maintenance, sustained maintenance, is lower, the chance of. So what is the ideal point? The ideal point, in my opinion, this is the short answer to you, Andrea, is psychoeducation. So you must tell the patient what you are. You must be aware. Please don't feel this like a stigma. Being bipolar, being unipolar, being tripolar, fourpolar, whatever polar you want, this is a medical relevant condition. I'm not making an apology of this. Please be aware. But still, I don't want any of us as a psychiatrist, as potential patients, relatives patients or even other foreign patients, they don't need to shadow their condition. They must know what it is, what they are. I said before that bipolar disorder is something that nowadays we cannot treat. It's like primary diabetes. It's like essential hypertension. We cannot heal. But still, if you do recognize well early in the time, you can ideally do the best strategies. So the shorter the duration of untreated illness, the higher the propensity of the patient to heal. And this is why treatment resistant in bipolar disorder is on the opposite side of the coin, is usually considered as a long-term stage of neuroprogression.
Yes, very good.
Thank you. I don't know if we have just one more minute. We don't.
Any question?
You know why? Just a few seconds if I can. Because this kind of question allowed me to think about Emil Kraepelin. I don't know, actually I know something in the North American setting of psychiatry because I spent a few years in the US, either in Boston a few years ago at the Mass General Hospital, which is an auxiliary site of the Harvard Medical School, and Columbia University in New York, and then a few months in San Diego. So and I have friends, Dr. McCarthy and other people are still in touch with me. So I know that psychopathology is regarded, but please, don't be offended by this, but sometimes I should say that Europeans are more in love, more informed of psychopathology. So let's go straight to the point. Emil Kraepelin, to most of us in Europe, at least in Europe, Emil Kraepelin is still considered probably the most important, the outstanding personality in clinical psychiatry. It was sometimes considered the prototype of biological psychiatry, even he had no real biological treatments, not what you should consider biological treatments today. So you read why we are talking about, I'm talking about this, I'm mentioning this right now, because at that time, Emil Kraepelin had no treatment-resistant patients. Actually, he may have, or actually, he should have considered to have some, but indeed he hadn't, he had not. So what happened there? So Emil Kraepelin was a young guy when he moved from his town in Germany with his fellow, the other friend was also a psychiatrist, and they moved to the nowadays is called Estonia, which is a country in the Baltic area of Europe, in the northeastern side of the Baltic Sea, and there they decided to split their activity. So I'm in charge of young people. He's in charge of old people. So the first one was obviously Emil Kraepelin. The other guy here, the name, you know what the name was? His name was Alois. But you know the family name? The surname was Alzheimer. So he was the one in charge of the old people reaching his attention. So they were Germans. At that time, Estonia, what is nowadays called Estonia, the Baltic Sea regions, were part of the Teutonic Empire, which was ruled by the Germans, so were German language. Unless you were a peasant or something, a farmer or somebody with little education there, otherwise other people had to speak German language. So at that time they were not fluent in the local language, neither Alzheimer, neither Kraepelin. So what they did were they just got the patients, they treated the patients with tea, tobacco, coffee, ice cold showers, this kind of very effective treatments. So unfortunately, or maybe fortunately, in my opinion, fortunately for some patients, these kind of treatments were not that effective. So they were able to follow the natural course of the disease, not the course of the disease that was affected either for the better or for the worse by the treatment. So nowadays we have no such opportunity anymore because of regardless what people, they either receive treatments, psychotherapy, drugs, prescription drugs, or neuromodulatory intervention, or they find drugs in the street. No matter what, they will find a sort of treatment. So natural course is something that we cannot see anymore. At that time, they had they were very lucky also for one other reason, in my opinion. They were not fluent, they could not speak the local language. And this is obviously a joke, But in my opinion, for a psychiatrist, you must speak with the patient, you must listen to the patient, but it's better not to listen too much. Because if you do that, you go into interpretations. So unless you are someone who is able, who knows what he or she does, unless you have a very strong background, it's better to refrain from doing that. So at that time, they were able to collect life charts, so the events. So treatment-resistant cases is something that we don't have in the current guidelines, but not even in the historical textbooks of psychopathology. So this is another issue, in my opinion.
Yes, very important to mention. Excellent. Thank you very much.
Thank you, guys.
Excellent.
Thank you, guys.